take a moment, just consider your arm. Beneath that familiar surface, there's this whole hidden universe.
Absolutely. A really complex network of vessels.
Yeah, and vascular surgeons, they navigate this landscape with, frankly, incredible skill.
Oh.
So today, we're plunging into that fascinating, unseen world.
Exactly. We're doing a deep dive into the surgical exposure of blood vessels in the upper extremity.
Mm-hmm.
And our guides, well, they're chapters from a really comprehensive vascular surgery textbook. It gives us a detailed roadmap, of the techniques and the crucial things to consider for accessing these vital structures.
Think of this as maybe your express route to understanding the key strategies. What's immediately obvious is that getting access isn't a one-size-fits-all deal.
Not at all.
For planning, surgeons actually divide the upper extremities vascular system into 3 distinct zones. There's the intrathoracic zone, closest to the heart.
Right.
Then the thoracic outlet, that more confined area near the shoulder.
Mm-hmm.
And then, well, the arm itself.
And each of these zones, they present their own unique set of challenges, really. The intrathoracic zone, because it's so close to major organs and vessels, that often means more extensive surgical approaches.
Your operations.
Yeah. And the thoracic outlet, well, that's a really tightly packed region. Critical nerves run right alongside the vessels, so it demands, meticulous precision.
And even the arm. Seems simpler, but...
Even the arm, while it seems less complex on the surface, it still has its own anatomical quirks that surgeons absolutely have to be aware of.
Absolutely. And doing the research for this, we definitely uncovered some surprising details.
Oh, yeah.
For instance, did you know the way our main artery, the aorta, branches off in the chest? It can actually vary quite a bit person to person.
Interesting.
Or the clever ways surgeons might, temporarily separate muscles just to get the view they need. Okay, let's unpack this. Let's start with zone 1. The intrathoracic vessels.
Okay, zone 1. So this initial zone includes the major blood vessels really close to the heart. We're talking the aortic arch itself, that big curved part of the aorta.
Right.
Along with the innominate artery, the subclavian arteries heading to the arms, the innominate veins, and the superior vena cava, which brings blood back to the heart from the upper body.
And the scale of intervention needed here, that's what's striking. Right, to get to these.
It really is. Because they're so central, exposure often requires these bigger operations, like a sternotomy.
Splitting the breastbone.
Exactly. Or even a thoracotomy, opening the chest cavity itself. And you can imagine, especially in trauma, where every second counts.
Oh, yeah.
The time needed for that kind of exposure. It has major implications for patient outcomes.
It must do. So in trauma, if you suspect an injury there.
Then getting proximal control, meaning stopping the bleeding as close to the heart as possible, that becomes the absolute #1 priority. Fast.
Makes sense. Now, when we think about the aortic arch, I guess we have a standard picture in mind.
Most people do, yeah. The textbook picture.
But you're saying there are common variations in how the arteries branch off.
There are. The typical pattern, after the aorta gives off the corners for the heart itself, the first big branch is the innominate artery.
Yeah.
That then quickly splits into the right subclavian for the right arm and the right common carotid for the right side of the head and neck.
Got it.
Next, coming directly off the aorta, is the left common carotid, then the left subclavian artery. That's standard. But in roughly maybe 13% of people, there's a variation called a bovine arch.
A bovine arch. Okay, that's a memorable name.
It is. And what it means is the left common carotid artery doesn't have its own separate origin from the aorta. Instead, it comes off either directly from the innominate artery or it shares a common starting point, a common ostium with it.
13%. That's common enough you'd really need to know about if you're operating there.
Oh, absolutely. Surgeons have to be aware. It really highlights how, slight shifts during embryonic development can lead to these lasting anatomical differences. You need good pre-op imaging.
Definitely puts it in perspective. A seemingly small difference, big surgical implications.
Precisely. And there are other variations, less common, maybe, but critically important.
Like what?
Well, one is the aberrant right subclavian artery. That happens in, say, up to 2% of people.
Aberrant right subclavian.
Okay.
In this case, the innominate artery basically just gives rise to the right common carotid, the right subclavian artery. It originates as the very last branch off the aortic arch.
The last one, way downstream.
Usually from the descending aorta, the part heading down. So it has to take this weird path.
So a detour to get to the right arm.
Exactly. It has to travel behind the esophagus.
Behind the food pipe.
Yep, to reach its destination. Now, a lot of people have this and no problems, but sometimes.
Sometimes.
It can lead to aneurysmal degeneration. The artery wall weakens, bulges out. It's called a diverticulum of Comro.
And that can press on the esophagus and cause difficulty swallowing. It's called dysphagia lusoria.
Wow. Definitely something you'd want to spot beforehand.
Yeah.
What's the other critical variant?
The other main one is when the left vertebral artery, that's one of the key arteries supplying the brain, originates directly from the aortic arch itself instead of its usual spot on the left subclavian artery.
How common is that?
Happens in about 2 to 5% of people. Now, this might not need surgery on its own, but knowing about it is absolutely crucial if you're planning a TAVR procedure.
TAVR. That's the endovascular aneurysm repair in the chest.
Right, using catheters. You absolutely do not want to inadvertently cover up or block off that vertebral artery during TAVR.
Yeah.
That could have, serious neurological consequences.
So understanding these anatomical blueprints, even the rare ones, is just paramount for safety.
It really is. And like we said, in trauma in this zone, that need for potentially extensive exposure just hammers home why getting that proximal control quickly is so vital. Stop the bleeding.
Right. So what about elective access then? If you need to get to the innominate right subclavian, left common carotid, or the start of the left subclavian, what's the standard approach?
The standard surgical approach is usually a median sternotomy.
The incision down the middle of the chest through the breastbone.
Correct. And if you don't need to get right onto the aorta itself, sometimes you can do a limited sternotomy, just the upper part. It gives excellent visualization of these big vessels.
Okay.
There's a superficial vein, the left innominate vein that runs across the field. Ideally, you preserve it, but in an emergency, you can carefully sacrifice it if you absolutely have to get access.
And nerves. Always a worry.
Always. 2 nerves here are particularly vulnerable during this approach.
Which ones?
The right recurrent laryngeal nerve, that's key for your voice. It loops right around the right subclavian artery, just where it branches off the innominate.
Okay, critical spot.
Very.
Yeah.
And the other is the phrenic nerve. Vital for breathing, controls the diaphragm. It runs behind the jugular and right innominate veins, then in front of the right subclavian artery, and sort of alongside the innominate artery.
So both are really close to the action.
Extremely close. They need meticulous identification and very careful protection. Any, indiscriminate dissection there could easily injure them.
Sounds like very careful, knowledge-driven work is essential. What if time is absolutely critical, like a major bleed from the left subclavian?
In those really critical situations, you need a faster way to get proximal control. An anterolateral thoracotomy helps there.
That's an incision on the front and side of the chest.
Yeah, usually through the third intercostal space, between the third and fourth ribs. With the patient lying flat on their back, it allows quicker access to the left subclavian.
But maybe not enough room for a complex repair.
Often not, no. It's really about stopping the hemorrhage quickly. That's the immediate priority.
Makes sense. Get the bleeding stopped first.
Exactly. Then, once things are controlled, you can potentially extend the exposure if needed for the full repair. Sometimes, for really broad access in very complex situations, surgeons might use what's called a trapdoor exposure.
Trapdoor, sounds dramatic.
It's a big exposure. It combines that anterolateral thoracotomy with a median sternotomy and another incision above the clavicle, the collarbone.
Wow. So it really opens things up.
It does. Provides a very wide field when you're dealing with complex injuries involving both the chest and the base of the neck.
We focus mostly on arteries here in Zone 1. What about the veins? Big veins there too.
Good point. Significant venous injuries are critical too, and they often happen alongside arterial ones.
Right.
So the basic principles of exposure are similar. Getting to the superior vena cava, the SVC, that really needs a formal sternotomy for good visualization.
Okay.
But for the more central part of the subclavian vein, where it joins the internal jugular, or for the innominate veins themselves, there's some other specialized techniques, especially for things like venous thoracic outlet syndrome.
Ah, venous TOS. That's when the vein gets compressed up there, causing arm swelling and stuff.
Precisely. Structures like the clavicle, the subclavius muscle underneath it, ligaments, they can squeeze the subclavian vein, especially in muscular people or those doing repetitive overhead motions.
And repairing that needs access right up near the chest.
Often very central exposure, yeah. Which can be tricky to get just from below the clavicle sometimes.
So how do surgeons tackle that?
There's a specific technique often credited to Dr. Malina. It involves first taking out a piece of the first rib. You can do that through an incision below or next to the clavicle. Then you do a limited median sternotomy just down through the first intercostal space below the first rib.
Just a small opening in the sternum.
Right. Then, after careful dissection, the whole sternoclavicular complex where the breastbone meets the collarbone is gently rotated upwards.
Rotated upwards.
Yeah, like a hinge. It's a clever move that gives excellent visualization of the innominate veins all the way to the SVC. Then, when you're done, you just securely reattach the sternal piece.
That sounds really ingenious. Gets the access without a massive sternotomy.
It is. It's a great balance between exposure and minimizing invasiveness. And one last thing for zone 1. In really tough cases, like chronic vein blockages where standard AV access for dialysis is impossible,
Yeah.
surgeons can sometimes use the right atrial appendage as an outflow pathway.
The appendage of the heart itself.
Wow. It's an innovative approach. You can get to it pretty easily through a small thoracotomy, maybe third interspace in the front. Open the pericardium, the sac around the heart, and the appendage is right there. You can clamp it and use it for outflow in these very challenging situations.
Okay, zone 1. Clearly critical, high stakes, needs deep anatomical knowledge, lots of surgical skills, and adaptability for variations. Let's move distally now to zone 2, the thoracic outlet.
Right. Zone 2, this is the area from the base of the neck down towards the armpit.
Okay.
It holds the subclavian artery and vein, the beginnings of the vertebral artery and vein, and the start of the axillary artery and vein as they head into the arm.
And what makes this area tricky?
It's the confined space, mainly. You've got the clavicle, the deltoid muscle nearby, and a really dense network of vital nerves.
Nerves like?
The brachial plexus that controls your whole arm's movement and sensation, and the phrenic nerve again, crucial for breathing. It all runs very close together.
Sounds like a very crowded, delicate neighborhood to work in.
It definitely is. For exposing the subclavian artery in this zone, the most common way in is from above the clavicle, a supraclavicular incision.
Okay.
This is used a lot in elective cases, like doing a carotid subclavian bypass to restore flow, or treating thoracic outlet syndrome itself.
But in trauma, same caution applies.
Absolutely.
No.
Have to reiterate, if you suspect a subclavian artery injury in trauma, and there's a hematoma, a blood collection above the clavicle, think about getting proximal control in the chest first. Manage that potential massive bleed.
Right. Proximal control first. So using that supraclavicular approach, what landmarks does the surgeon see?
Okay, so you make the incision, divide the platysma muscle, that thin sheet in the neck, and the clavicular head of the sternocleidomastoid, the big neck muscle. Then you had a fat pad. It varies in size. Inside that fat pad is the omohyoid muscle.
Okay.
You usually divide the omohyoid, move the fat pad aside, and then deeper down, you identify the anterior scalene muscle. That's a key landmark.
And this is where finding and protecting the phrenic nerve is super critical, right?
Absolutely essential. The phrenic nerve has this very characteristic path across the anterior scalene muscle. It runs from lateral out towards the side to medial towards the midline as it goes down into the chest.
Lateral to medial.
It's the only nerve in the body that does that. Finding it and carefully protecting it is critical. Injury can cause significant breathing problems, even if you're not very active.
Wow. A nerve you definitely handle with extreme care.
For sure. If you don't see it right away on the muscle surface, you look carefully, maybe a bit more medially, and if it's still hiding, any further cutting of the anterior scalene has to be done very slowly, very cautiously.
Why is that?
Because sometimes in anatomical variations, the nerve can actually run through the muscle fibers.
Oh.
And it's also not uncommon to have a bifid phrenic nerve split into two branches. One helpful trick is to find the upper roots of the brachial plexus first, C5 and C6 nerve roots, and trace them carefully until you see the phrenic branching off.
So a very meticulous, step-by-step process. Anatomy and variations are key. Once the phrenic is safe, what's next?
Well, if you're doing, say, a carotid subclavian bypass,
Rerouting blood flow from neck to arm.
right, then the anterior scalene muscle is usually fully divided, right where it attaches to the first rib. Some surgeons might not divide it completely, but there's a strong feeling that leaving it intact could maybe compromise the bypass graft long term.
Oh, okay.
So phrenic nerve safe, divide the anterior scalene. Often a piece of it is removed too, to stop it scarring back down and potentially compressing the graft later. Once that's done, the whole subclavian artery, from under the SCM muscle down to the first rib, is nicely exposed for the procedure. And remember, the vertebral arteries coming off the subclavian, they arise more medially than you might think, often under the cover of the SCM muscle itself.
Okay, so the supraclavicular approach gets you the subclavian artery above the clavicle. What about the bits right under the clavicle?
Yeah, that specific spot is notoriously hard to reach directly with a standard incision.
Hmm.
However, a claviculectomy removing part, or all of the clavicle, the collarbone,
Removing the collarbone.
it's actually a surprisingly well-tolerated option, and it gives excellent rapid exposure to both the subclavian artery and vein in that tricky spot right underneath.
Interesting. I wouldn't automatically think well tolerated for removing a collarbone.
It might sound drastic, but functionally, most people adapt remarkably well, especially if it's done carefully, preserving surrounding structures. Now, the subclavian artery officially becomes the axillary artery as it crosses the outer edge of the first rib.
Okay, that's the transition point.
Right. It arches over that first rib, passes under the clavicle sitting above the subclavian vein. The axillary artery itself is easier to get to from below the clavicle and infraclavicular approach, though it's still above the axillary vein there and might need a bit of digging to find.
So the best approach depends on the specific problem.
Totally. Give you an example.
Yeah, please.
Okay, say a patient has an aneurysm, a bulge in the subclavian or axillary artery, maybe caused by a bony issue from thoracic outlet syndrome, like an extra cervical rib or a weird fibrous band.
Right.
A paraclavicular approach is often used, incisions both above and below the clavicle. That lets the surgeon control the subclavian artery above and the axillary artery below.
Gotcha. Control on both sides.
Exactly. Then you can put in a bypass graft around the aneurysm after you've removed the abnormal bone or band and maybe the first rib to fix the underlying cause.
Okay.
Now, if the artery lesion needs direct repair, not a bypass, then maybe a claviculectomy is the better route for the best possible view.
Makes sense.
For other things, like an axillofemoral bypass, tunneling a graft from the armpit down to the groin for leg blood flow, you expose the axillary artery as far medially as close to the chest as you can, often under the pectoralis minor muscle. Then you tunnel the graft deep to that muscle and make the connection so it's less likely to get pulled or kinked later.
So definitely tailored strategies for different challenges in this zone.
Yeah.
What about the subclavian veins here? How do you access them?
Okay, the subclavian veins. They lie below inferiorly and closer to the skin more superficially than the arteries here.
Right.
They're most often accessed surgically to treat venous thoracic outlet syndrome, that compression issue we talked about.
Okay.
Now, you can sometimes use a supraclavicular approach from above, but it's often really hard to get a good enough view of the veins that way.
Why is that?
Because the veins continue down below the clavicle, so the preferred approach is usually infraclavicular below the clavicle, and often, like we mentioned, involves taking out part of the first rib if it's venous TOS causing the problem.
So below the clavicle gives a better view of the vein.
Generally, yes. Much better direct visualization as it passes under the clavicle. The procedure usually involves an incision right over the first rib.
Okay.
Then you carefully separate or divide the upper fibers of the pectoralis major muscle, the big chest muscle that exposes deeper layers. Move aside a fat layer, and you find the lower edge of the first rib.
Got it. Follow the rib.
Follow it medially towards the midline. The subclavian vein is just lateral to it. Trace it inwards. If the subclavius muscle, another potential squeezer, looks enlarged or involved, you resect it off the clavicle.
Remove the muscle bit.
Yep. And any fibrous tissue and ligaments in there that might be compressing the vein, you carefully resect those too, from the clavicle down to the first rib.
Clearing the space around the vein.
Exactly. That fully exposes the top and inner borders of the first rib, right up to where the anterior scalene muscle attaches. Then you carefully divide the anterior scalene muscle itself. Gently pull back the middle scalene muscle fibers, expose the back part of the first rib, and divide it as far back as safely possible. And divide it at the front, too, near the cartilage.
So you're taking out a whole segment of that first rib?
The whole segment that's causing the compression, yes. Then you remove it. And, importantly, smooth down any remaining bony spurs or sharp edges that could still press on the vein.
Wow, quite a process to free up that vein.
It removes the compressing structures,
Right.
frees the vein, lets blood flow better. And if you need even more exposure towards the chest, that Malina sternoclavicular rotation technique we talked about can be used here too.
Right.
Getting exposure further out in the arm, more distally, that's usually less complex. Just careful soft tissue dissection.
Okay, so addressing venous TOS can be pretty involved, often needing that rib resection.
It can be, but it's often the most effective way to relieve the compression and fix the blood flow issue. And just finally on zone 2, accessing the axillary vessels way out from the side, laterally, that's really limited by the big deltoid shoulder muscle. You could theoretically cut the deltoid in a dire emergency for immediate access, but there's generally no other routine reason to expose the axillary artery deep under the deltoid.
Okay, that brings us logically to zone 3. The blood vessels just within the arm itself. After hearing about all the complexity up higher, this zone sounds like it should be maybe comparatively straightforward.
And yeah, for the most part it is. Surgical exposure of arteries and veins in the arm, generally much simpler than up in the chest or thoracic outlet.
Easier access.
Much easier. If there's trauma involving arm vessels, direct surgical access is usually pretty readily achievable for an experienced surgeon. Plus, even with significant bleeding from an arm vessel injury,
Yeah.
direct pressure often works well to control it. And you can easily safely put a tourniquet on the arm to limit blood loss further.
That's definitely a relief to hear after the more involved exposures higher up. Where in the upper arm are vessels typically accessed?
The brachial artery, the main upper arm artery, is frequently accessed below the deltoid muscle on the medial side, the inner side of the biceps muscle.
Okay.
This is the main inflow artery for upper arm AV grafts for dialysis access.
Right.
And it's also used for DRLL procedures, distal revascularization interval ligation, which treats Steele syndrome in patients who already have an AV fistula.
Okay.
The veins nearby are also exposed, obviously, to create the venous side of those AV grafts.
And the artery itself, deep or superficial there?
In the upper arm, the brachial artery is typically deeper than the brachial vein and the median nerve that run with it, but getting to it isn't usually that difficult.
Nerves to watch out for.
Well, the median nerve definitely needs careful identification and protection. But the superficial sensory nerves in that area, even if they're fairly large, dividing them usually doesn't cause major long-term issues for the patient.
Okay. What about the deep vein?
Interestingly, unlike in the leg, the deep brachial vein in the arm can be tied off, ligated, or sacrificed without causing significant circulatory problems. Yeah, which can actually be helpful sometimes, like when creating a specific type of fistula called a brachiobasilic fistula, connecting the brachial artery to the basilic vein.
Good to know. What about nearer the elbow? The antecubital fossa?
Yes, the bend of the elbow. The brachial artery there is very commonly exposed. It's the inflow for, something like 80% of all upper extremity AV access procedures.
Wow, the vast majority.
Yeah. And it's used for diagnostic imaging access interventions for some chest conditions too.
So how do you approach it there for, say, a brachiocephalic fistula?
Connecting brachial artery to cephalic vein in the forearm. A transverse, horizontal skin incision just slightly distal, a little further down from the elbow crease is usually best.
Why below the crease?
Well, it might seem tempting to go higher up the arm, maybe thinking you'll avoid kinking the vein. But the cephalic vein actually runs more laterally towards the thumb side as you go higher up the arm.
So it moves away from the artery.
Exactly. An incision just below the crease usually lines things up most directly. Also important. The bicipital aponeurosis, that strong tendon band from the biceps, it covers and protects the artery there, but it's easily and safely divided to get right onto the vessel. Knowing exactly where the cephalic vein is and any connecting veins is key for efficient access creation there.
Makes sense. What about further down the arm past the elbow?
Just distal to the antecubital fossa, the brachial artery is often exposed for the distal part of that GRL procedure we mentioned.
Right, for Steele syndrome.
Yeah. The goal there is to get good flow down to the hand, while stopping too much blood flowing backwards from the artery into the existing fistula.
Okay.
To do that, you need to ligate tie off the brachial artery itself, just proximal to, just above, where it splits into the radial and ulnar arteries.
So precise location for the tie-off.
Very precise. A longitudinal vertical incision usually works well here. There aren't super specific surface landmarks, but the artery is usually easy enough to find.
And if not?
If it's not obvious, sometimes temporarily blocking flow in the existing fistula can help you feel the pulse downstream, or you can use a handheld Doppler ultrasound to listen for the flow. Once you find it, ligation must be proximal to the bifurcation for the DRL to work properly.
Got it. Precision matters. Moving right down to the wrist now. What's accessed there most often?
Wrist level, it's usually the radial artery and the cephalic vein. For creating a radiocephalic fistula, the most common type of AV access for dialysis.
Okay.
A longitudinal incision works well. You typically follow the radial pulse you can feel on the thumb side of the wrist. The artery lies between a couple of tendons there, flexor carpi radialis and brachioradialis.
Anything tricky there?
Nerves. Yes. The main thing to be really careful about is the radial sensory nerve.
Oh.
It's relatively small, but injuring it can, surprisingly, cause significant and persistent numbness, tingling, or pain in the hand. Really quite debilitating for the patient.
Wow. Okay, so protect that nerve carefully. What about the vein?
Cephalic veins, usually easy to spot in the tissue there. Generally, the more lateral branch of the cephalic, which tends to run a bit deeper, is considered the best choice for the fistula.
Okay.
And there's some evidence that handling the vein as little as possible during the procedure might improve how well the access works, both early on and long term.
Gentle handling helps.
Seems so.
Yeah.
And just briefly, in some cases, you can create, we'll call a snuff box fistula.
Snuff box.
Yeah, exposing the radial artery within the anatomical snuff box, that little triangular dip at the base of the thumb on the back of your hand.
I know the spot.
The artery is quite superficial there and relatively large, so it's another option for AV access in certain patients.
The anatomical snuff box, another great anatomy term. Okay, finally, the ulnar artery. The other main forearm artery. We haven't talked much about accessing that one.
No, and the ulnar artery is very infrequently exposed for primary AV access creation.
Why is that?
Mainly because it's generally considered the dominant artery supplying blood flow to the hand in most people.
Ah, the main supply.
That's the thinking. Now, the hard scientific evidence to absolutely back up avoiding it isn't maybe super robust or universally agreed on, but it's definitely the prevailing general practice among vascular surgeons. Avoid the ulnar if you can for access.
Okay.
If you do need to expose it for some other reason, you just palpate the ulnar pulse and follow it down to find the artery.
So from that really intricate network inside the chest all the way down to these finer vessels in the wrist, it's truly a testament to the incredibly detailed anatomical knowledge and the sheer variety of surgical approaches surgeons use.
It really is. As we've kind of explored in this deep dive, even parts of the body that seem simple and familiar, like your arm, they contain these incredibly complex and vital vascular landscapes.
Hidden worlds.
Exactly. And surgeons skillfully navigate them. They have to choose just the right approach based on exactly where the problem is, what the underlying condition is, and always balancing the need for speed with the need for absolute precision.
Absolutely. It is easy to just take for granted that huge, intricate network of vessels just under our skin. So maybe something to think about as we wrap up. We've talked about how even seemingly minor anatomical variations, like how the aorta branches, could have really significant impacts on surgical planning and patient outcomes. What other, maybe seemingly unremarkable areas of our body might hide similarly critical yet often unseen vascular complexities that demand just as much meticulous care and expertise from surgeons?